So the second standard tool I want to teach you today is called the Palliative Performance Scale, or PPS. And this is a local tool. This is developed in Victoria, developed by Michael Downing. He's actually still working at Victoria. He's the head of research at Victoria. And when I did my elective down there, my palliative care sabbatical, I worked with him on a couple of nights on call there. Really interesting guy. It's a functional scale, so it talks much less about symptoms, but more about what you can do or what you can't do in your life. So this is much more to do with your disease trajectory. And it, again, like the ESAS, allows precise communication between professionals about where that patient is on their disease. It helps map the disease progression with life transitions, and I'll talk a little bit about life transitions. And it helps with prognostication as well. And I'll talk a little bit about prognostication with different PPSs later as well. Here it is. The most important thing is that scale on the left-hand side there, from 100% to 10%. And a skilled nurse or doctor in palliative care will immediately know what a PPS of 70% or 30% means. And I should say that this PPS is best applied to cancer. It was actually designed to be applied for cancer patients because of that smooth trajectory. It's lousy for organ failure, usually. Unless there's some sort of slow progression in the organ failure, it's really not good for mapping out that roller coaster organ failure that you get. It's not bad for frailty. And especially it is applied to dementia, which is a terminal disease. There's certain transitions that you really need to know about. So 100 is, again, you on a Monday when you've had your cup of coffee and you're out of the door and the world is great and the birds are singing. Nothing's wrong with you. From 80 to 70 is an important transition there, especially if you're talking about cancer. Once your PPS goes from 80 to 70, it's no longer a private disease. It becomes public because you can't get to work anymore. And you may be able to hold it together from a PPS of 190 and 80, but you're starting to show signs at 70. And really you're going to be off work. You might be hobbying around the house, doing a little bit of gardening, but you're going to really be feeling different. The next big transition, I would say, was from 60 to 50. From 80 to 60, you're sort of around the house, you're doing things that you want to do, catch up a little bit around the house, maybe taking a lot more naps. But from about 50 onwards, you really can't do much work. You're sitting down or lying most of the time. And hobbies are pretty much gone by then, and the disease is really starting to show. The next transition I say is from 40 to 30, and that's an easy one. You're in bed. You're really not getting out of bed once your PPS is 30. And the final one is 10%, which is really unconscious. So you can probably work out that the lower your PPS, the easier it is to predict when you're going to die. And there's a whole list of data around PPSs and when people are going to die, and it's all published by the Victoria Hospice. I don't have enough time to go into it today, but here's a nice little one which you can just hang your hat on. If you have a patient with cancer who has a PPS of 10%, they have a 90% chance of being dead within a week. Now, the extraordinary thing I find about that statement is that it means they have a 10% of not being dead within a week. And that's often with no liquid and certainly no food. But that's a really good one to be able to tell patients, because patients will often be looking to you, well, caregivers will often be looking to you to say, well, how long do they have? And the first thing you have to say is you don't know, but that's a pretty good, accurate prediction. So if we look at the PPS and disease progressions, that 70% there is when they're having decreased functioning, disease advancement. 50% they're really decompensating and they're life-limiting. 30% is they're completely dependent and in bed. 10% they're unconscious. And then, of course, don't forget that we go on with bereavement. So here's the educational aims again. I want you just to look at them to see whether you feel they have been met, and if haven't, I'd like you to ask me some questions. And you can ask me questions about other things as well. Thank you.